So I'd like to welcome everyone to our first ever RTi3 National Innovation Snapshot. And as many of you know, especially those who are about to speak today, it's a little bit of an experiment for us, but it's really all about highlighting what's going on around the country in all the different centers and the breadth and scope of innovation that's happening at the front lines in radiation therapy. So I'm just going to give a short overview of innovation in general and the motivation for this session. And then each of our 14 speakers representing centers around the country is going to have 3 minutes and 3 slides to present their innovation. So it really is a snapshot, and I encourage all of you to track these speakers down afterwards at the breaks, at lunch, to follow up with them and to delve a little bit more deeply into some of their innovations. So the impetus for this session was really the cultivation of a community of practice, and I think we can be better as a profession about engaging each other and learning from each other in the successes we have in our own centers. So this session evolved from a desire to engage those who may not be fully immersed in a research culture in research. We often don't appreciate that, research isn't always a clinical trial with 500 patients accrued to it. It's often just the small little things that are happening at a local level that stem from a question that someone had or a gap that was acknowledged that someone decided to pursue and find a solution to. So in the fall, we sent out an invitation on behalf of RTi3 to all Canadian radiation therapy centers, of which there are about 42, 43 in the country right now, to identify an innovation and to send a participant. So we basically told everybody, we've held a 3-minute slot for you. If you choose to fill it, send someone and tell us what you'd like to talk about. So it was a slightly different spin on the peer-reviewed competitive process that we often think of as at a conference like this. So the objectives of this session are to acknowledge the value of practice innovation. It might not be capital R research, but it's still extraordinarily valuable to our practice. To highlight the scope and nature of the initiatives around the country that are improving and informing practice, and also to foster communication and collaboration between our centers and the centers faced with similar practice challenges. So a little definition of innovation, and what I'm going to cover in the next couple of slides is actually covered in a chapter in our new research book by Colleen Dickey and Amy Parent about the value of innovation and invention to our practice. So the definition of innovation from West is the intentional introduction and application within a role, group, or organization of ideas, processes, products, or procedures new to the relevant unit of adoption designed to significantly benefit the individual, the group, or wider society. So there are 2 kinds of innovation. There's product innovation, which is the development or improvement of physical goods, devices, or services. So that's often attached to the idea of invention and patenting of products. And there's also process innovation, so the enhancement of steps or approach and delivery of goods, devices, or services. So I believe most of what we're covering today is process innovation. And then within that, there are two types of innovation in terms of scope. There's disruptive innovation, which is seen as revolutionary or radical in nature and necessitates an overhaul or a complete change in roles and practices. There's also sustaining innovation, which is by no means less than disruptive innovation, but it has a different impact on a department or on an organization. And sustaining innovation improves performance of existing products or processes. So just as a couple of examples of innovations in our field on a large scale, the idea of CT simulation was something that is a product innovation. It's also disruptive, so it fundamentally changed how we approached practice when CT simulation was introduced, and it affected the roles and the responsibilities in our approach to practice. Peer review, extraordinarily valuable to practice, I think we can all appreciate. It's a process innovation, it's the introduction of a new practice or a new model of working, but it's really a sustaining innovation. It's not something that really changed how we did things and what our roles were, but it's introducing a valuable QA innovation. IMRT, for an example, is a product innovation. It's also disruptive. Again, it completely changed how we approach practice. VMAT, however, while an extraordinary advancement in how we deliver care, was sustaining. It didn't actually change our roles on a large level in terms of planning and delivery of care, and it was also a product innovation. So the process of innovation is really, and this is how all of our speakers are going to approach their talks today, it's really about the identification of a gap in practice or a bottleneck or something that's just not quite working right, the identification of an innovation or an approach that might address that gap, and finally, looking at the outcomes and the progress attached to that, and whether that innovation actually achieved the goal that we were hoping to, and what kind of changes needed to be put in place to achieve the goal or to fully address the gap. So this is sort of how everybody is going to be approaching their talks today. So the format, as I mentioned, we have 14 centers represented here, 3-minute presentations. It may be a little bit comedic. I was telling them all there's going to be a trap door that opens in the floor, and you'll fall through if you go over your 3 minutes. But this is new to us, so it's a bit of an experiment, but we're really excited about it. As I mentioned, all presentations will involve an identified gap, an innovation, and a discussion of the progress and outcomes. After each group of 5 speakers has presented, we'll have a Q&A. They'll all be up here, and you can ask an individual a question, or you can present a general question to the group that's up here. So that's after each of 5 speakers will have that. So it's not after each talk. We want to keep things running smoothly. All right, so this is the first 5 sessions are coming now. So here we go with the TrueBeam Exactrack system.
Hello everybody, and first of all I'd like to start off by thanking the organisers of this committee for inviting myself here to come and showcase what's happening in our department. And as Kaitlyn said, there is only 3 minutes, and I timed myself and I'm way over that. And I do have time management issues, as everybody who knows me is very aware. So please track me down with questions afterwards if you would like to ask me anything, because I will have to rush through this now. So my name is Clare Summers, and I'm a therapist at the Nova Scotia Cancer Centre in Halifax. And I'm going to talk about how we implemented our lung SBRT program there using the Exactrack system on a TrueBeam SDX. So our department was going under major renovations, basically. We were updating our outdated equipment and looking to replace our SRS and SRT model of care that we had. So we were trying to find what else was out in the market, and we ended up buying the BrainLab Exactrack system, which is pretty much the well-documented gold standard for cranial radiotherapy. But we needed to expand that functionality of that equipment because, it's not a huge population base that we'll be using to treat that, so we needed to find some additional functionality to use on that equipment. So we started trying to find out what else we could use it for, and decided to implement a lung SBRT program in our centre. So we did a lot of research, trying to get this program started in our department. And we realised that there's actually not a lot of research out there. We managed to find one article that documented the use of the Exactrack system in lung SBRT. So we were initially getting going, picking our patient demographic of what we were going to use, and decided to use peripheral tumours to start with, and this presented some of the limits with the system that we were using. Now, the Exactrack system is primarily used to do bony matches, and obviously lung tumours are, soft tissue, so this presented some of the challenges that we were undertaking with that. So all the literature supports the use of cone beam CT to localise these soft tissue targets. Our very academic, strong medical physics department wanted to continue to use the Exactrack system as it's documented, which is for bony match. So we were, initially finding the challenges with this system. As a therapist, we did have some, conflicts trying to match on a bony anatomy, often removed away from the actual soft tissue target, and treating these patients with a high dose per fraction. So we were questioning this procedure, and eventually we managed to gain RO support to change our practices. So now we're able to champion a bit of evidence-based care, with the fact that there was no evidence to base our model of care and how we were treating the patients using the current Exactrack system. So we were able to eventually change our treatment procedure. And with that changes, we're also starting to implement radiotherapy or therapist-led research now to hopefully fill in the gap that we experienced when we were initiating this program in Halifax. So I'm getting a red light, so thank you very much. Please find me afterwards for questions.
Hi, Hi, my name's Allison Kelly. I'm a radiation therapist at Grand River Regional Cancer Center, and I'm going to talk about how we implemented what we feel is an innovative risk management strategy. So in 2011, we surveyed all of our radiation therapists to assess attitudes and barriers towards incident reporting. Our results showed that underreporting was a big issue in our center. The therapists were unclear on what to report and felt bad filing reports. Errors were frequently passing through QAs and being corrected without notification of those involved. There was also a general lack of communication surrounding incidents, and as a result, many errors were being repeated. The majority of errors were also being caught at time of treatment or pre-treatment, and leading to a lot of frustration on the treatment floor. So the innovation, it took a while to get started, but in 2013, we formed what we're calling a Quality Assurance Task Force, or QATF. We're a small center, 4 LINACs, about 33 therapists. We don't have the same resources as larger centers. All 4 members of the QATF are full-time clinical staff. So what we do, we analyze all of the incident reports that are filed. We look at incident origin, where the incidents were detected, as well as cause from a system point of view. However, we also look at and track who was involved with each incident. The individual stats are then compiled into customized individual reports, and these reports show the individual statistics against those for the entire department by incident category. So this was a bit of a controversial approach and was met with some initial backlash. With time, however, we've been able to prove to staff that these reports are non-punitive. Our manager does not see these reports. We know that no one intends to make errors and everyone wants to do their best. Our strategy is really all about awareness and not blame. The customized individual reports allow therapists to understand how they compare to the group. So for example, when people can see they're below the department average, they may feel better about their performance. Alternatively, when people see that they're above the average, we've seen that they've taken action in a positive way. So increased reporting, better documentation, not repeating the same errors. And in general, our reports have helped to increase therapist accountability for failing to follow guidelines and overlook aspects of the QA process. Here's just a couple graphs. There's a lot of information, but so prior to implementation, we were getting about 10 to 20 incident reports filed a month. We had 0 coming out of CT Sim and planning. We now average about 65, and that includes representation from CT and planning. So these graphs here show significant improvement, way more reporting and therapist involvement. A survey we did in November showed that 94% of our staff were supportive of our process. Other data shows that we've reduced our documentation errors as well, but we were drastically underreporting until about 6 months ago. We're still getting new types of errors reported every month, so we need a couple more years to really truly assess incident reduction. Thank you, and we'd love to hear from other centers if anyone's doing something similar.
Hello, everybody. My name is Patry. I'm the education coordinator at the Ottawa Hospital Cancer Center, and today I'm going to be talking about radiation therapists in the Durham clinic at the hospital. So I'm going to start off a little differently. I'm going to go straight to the results to pique your interest. So basically, the blue lines are the number of fractions treated. So you can see they went up a little bit, but they're fairly stable. But the red line is actually the wait times met, and you can see that in before 2012, we were about 60% meeting wait times, which is not great. But then we started this initiative of having the therapists in the Durham clinic, and you can see that we're up to 91%. So that's a huge improvement in basically a year and a half. So how does it work? It's fairly easy. The therapist is either in the room with during the consultation for the Durham clinic, or they're just outside the room, and the doctor will come and get the therapist when the decision to treat is made for ortho patients, of course. Then the therapist facilitates the markup. So this would be a simple markup. A gel trade or anything like that would be done during a separate appointment. And also the therapist coordinates the appointment time, so they get in touch with the booking clerk to make sure the patient has their treatment appointments already set before the patient leaves, hopefully happy. So some of the outcomes, I'll get through this real quick. I'm actually doing good for time. Decreased wait times, as we've noticed on the first slide. Decreased trips to the cancer center for the patients, which is really great for them. And anecdotal information that we got, we don't have any stats on this, but still very important, build rapport with the treating therapist. So the treating therapists are actually at the consultation visit, which is great, which decreases anxiety to the patient about their treatments, increases understanding, and of course, increases cooperation and compliance. For the therapist, there's the increase of knowledge, so the education piece that goes with being in a consultation and interacting with the oncologist, understanding of the treatments a little bit more since you're there from the beginning. The big thing is that we have 3 oncologists doing this, so we're tapping into 80 plus years of knowledge and experience in the Durham clinic, and the therapists also get to participate in some follow-up visits. They're not always in the follow-ups, but they do see some of the results that happen. For the oncologists, well, there's improved patient flow in the clinics, especially since their observation clinics aren't used for markups as much anymore, so that helps a lot. And a huge thing is the technical expertise that's readily available. So as therapists, we are the experts in the treatments, and we become the resources for the oncologist. So basically, at the end, everybody is happy, and especially the patient. Thank you.
Hi, I'm Pauline Warden. I'm here from Oshawa today to talk about IV contrast implementation. Okay, so the gap that we identified is that pre-2012 we actually didn't have any IV contrast enhanced planning scans at the Durham Regional Cancer Centre. We did need to get programme and corporate approval prior to implementation because this is a pretty high-risk procedure. And in order to get that approval, we had to ensure that we had considered and addressed key aspects to implementation. What did we do? We utilised the experts, and that might not seem very innovative, but we actually made those experts part of the team. Looking at the key aspects, patient selection and preparation, our radiologist was very much involved in the patient risk factors, screening, and patient education. We utilised our RT admin team and our patient care specialist for nursing to navigate those patients through the system, ensuring that they weren't adversely affected in terms of timeline, documentation, and we produced very robust documents. Our therapists were extremely enthusiastic in expanding their clinical competencies. They went through the CAMRT short courses, did much self-directed reading, shadowed the DI techs over in radiology, and they received training from our nurses as far as maintaining and discontinuing IVs. We went back to DI again, and they helped us with our contrast media selection, image acquisition protocols, the goals of visualization, lots and lots of troubleshooting. And this is the big one, and this is the one that we're really proud of. Critical care came to spend some very quality time with us. We did some mock anaphylaxis codes, and what we're really proud of the fact is that every radiation oncologist, every radiation nurse and all the radiation therapists in CT SIM actually attended those codes. We did some very, very detailed debriefing, and we actually put in some key critical procedures to mitigate the risks and ensure that we were very prepared for any emergencies that may occur. We successfully implemented the system in the summer of 2012. Maintained the team. The implementation team is still very much in effect, and critical care and radiology are still very much part of that team. We've done some post-scanning review with our radiologist colleagues, and they've given us some great tips and tricks to improve our scans. In the future, we want to continue that relationship we have, and I'm very conscious that I'm going to run out of time. Very proud of our integration of CPOE with our screening forms. With the screening forms themselves, when they're paper, they can be incomplete, they can be lost. So we actually utilise the umbrella of CPOE. All our forms are electronic. We've made all the fields mandatory. So a form cannot be submitted for CT IV contrast until those forms are complete, and regardless of where the doctor is, those forms will actually print in radiation, and that helps us greatly with all our peripheral clinics. Thank you.
Hi, I'm Tracey Hill. I'm from Thunder Bay Regional Health Sciences Centre, and I'm going to be talking to you about rocket rounds. So we identified a gap back in around 2009 at a patient family-centered care workshop. We identified that there was really a working group that needed to kind of come together to improve the collaboration between the radiation therapy department and the inpatient unit on the hospital. We were caring for the same patient, but we were in two very separate practice settings. So, for example, in the radiation therapy department, we thought that our outpatients were the main priority for scheduling, and we kind of considered our inpatient population as more of a fill in the gaps on the schedule. There were also communication issues between the healthcare providers in the radiation therapy department and the nurses on the inpatient unit. We had issues regarding scheduling, treatment start times, treatment finish times, side effects, that kind of thing. So also within the acute care hospital, being an acute care facility, they have guidelines that they have to meet in order to be fiscally responsible, and one of those guidelines is the length of stay for patients. So they have an awful lot of inpatients that are deemed alternate level of care, which means alternate level of service, which means that they don't require the intensity of services that an acute care facility provides. So we in Thunder Bay have something called code gridlock, and what that means is that we have no more beds for our patients. So that's an issue. So we need to really get the patients in and out fairly quickly. So the innovation was we needed to improve the communication between the radiation therapy department and the inpatient unit. So the radiation therapists now, we attend what's called the rocket rounds, and we do that. Those rocket rounds are held every day, but the therapist attends on a weekly basis, and those rounds consist of the physician, social work, OT, PT, dietitian, CCAC workers, and as well the nurses that come in to speak about their patients. So we attend those rounds. They take about half an hour every Wednesday. So it's truly an interprofessional collaboration. We talk about that and we teach that to our students, and this is actually happening. So we've had really good progress. It's been going on now for 4 years. The weekly attendance between 2010 and 2012 ranged between 98 to 100%. Attendance by the therapists, we're now down to about 87%. We've got start date improvements, so our patients now can get started within 24 hours of treatment, and that then helps the Thunder Bay Regional Health Sciences Centre gridlock issue. The scheduling is improved between the CT SIM and the treatment units. We're sharing information now about the patients, whether they're having tests that day, whether or not they're going to be able to come for treatment at that particular time. And it's also an educational opportunity. We can teach the nurses about the side effects and that sort of thing. So.
All right, so that's our first 5 presentations. I'd like to open the floor for any questions. So if you'd like to just go to the microphone, we're happy to take any questions for these 5 presenters. I think we have someone.
Hey guys, thanks very much. That was great. I have a question for all of you, actually. When you implement a new innovation, it's all very exciting and very sexy and everybody wants to get involved. What happens after a year of that innovation and you're trying to get people to still be engaged and practice in that way? Do you have any strategies for things that you've done to keep that energy level up with your innovation? Any of you?
Don't be shy.
I think it, and I don't want to speak on behalf of everybody, but I think it depends on what the innovation is and how big of a project it was. If it's a big project, I expect there would be some sort of sustainability gamut or something. If it's a very small project, sort of like the one I presented on the Durham clinic, it has a big impact on ortho patients, but it's not a huge thing, and the buy-in is very easy because the results are there, but that's all I have. Anybody else?
I'll let you know in a year.
I think with the rocket rounds, having the staff engaged and just knowing that that's improving the care for the patient is good. And it's enhanced our scope. You know, we're working now with so many different professions that are outside the realm of radiation therapy. So in that regard, I think that's appealing as well.
I just wanted to see if I could be less nervous talking on this mic than that mic in a second. I actually wanted to ask about the Quality Assurance Task Force. Does every individual in the department see the mistakes with names? Is that...
No, it's not. So it's all anonymous.
Okay.
Right now, the department stats, it's just an Excel spreadsheet, so the department stats are there, and then they receive an individual email. Okay. With their stats beside the group stats. So nobody knows, anyone else's involvement in anything.
Okay. All right, thanks.
I think I did notice, to varying degrees in your different presentations, the amount of work that went into planning for an innovation before it was actually implemented. So Pauline, for example, you spoke a lot about the amount of work that went into making sure that the innovation was implemented in the best way possible. Other people, it's sort of a trial and error sometimes where you put it in place and you learn as you go. And then in terms of evaluation as well, some of you have very formal evaluation. Allison, you were mentioning sort of the stats and how things have changed. I don't know if any of you could comment on, the level of rigor and formality about your innovations as compared to, the trial and error approach, and both can work. And if any of you have any comments on how you approached it.
I think with the IV contrast, there was not going to be any room for trial and error. We had an obligation to the first patient that we performed the procedure on, that we were experts. So there was a lot of rigor, and it actually took an awful lot of time. We needed to seek the affirmation from the people who are actually trained in that particular kind of procedure, but plus the people that have to deal with the consequences when that goes wrong. So once we got their confidence, we were confident, and we carry on with that. We still have mock scenarios, and we still have that kind of evaluation and feedback, and we do that in a group setting as well. So,
Angela, question?
Sorry, Pauline, I'm going to ask you another question. How do you maintain your competency for your staff? We went through initially not enough IV contrast orders. Now we're fine, but I know other centres struggle with this in terms of if they're not requesting IV contrast, then your staff are not maintaining those skills.
Yes, I think we're really fortunate actually, because we've got a really large lung portfolio, so there are always patients who need IV contrast, and the numbers are actually increasing. And as we've gained experience and we are opening up more treatment sites, we're actually doing IV contrast for all our gynae work, most of our GI work. So there's definitely at least 5 or 6 patients with contrast every week, and it's the same group of staff.
Hi, my name is Michele. I'm from the Juravinski Cancer Centre, and I'm speaking on behalf of my manager, Marsha Smoke, who is very excited about this model. It's a 4-day, 10-hour work week. So Marsha is very interested in improving quality of life for therapists, and one thing that we all sort of crave in our department is a little bit of flexibility, which has been built into this by allowing a little bit of innovation with our work shifts. This is hoped to improve recruitment and retention and basically the attractiveness of JCC. And I'm sure after I finish, you all want to work there. We started off with a volunteer base. Basically the model is that it's 5-day coverage with a single shift, rotating days off. 5 employees come in, but really only 4 each day. And the best way to explain it is to show you this table. So each table is a machine. So machine 1 and machine 2, very imaginative names. As you can see, Sue Saint-Marie works Monday, Tuesday, Wednesday, and Thursday, the 10-hour shift. Stand Up works Tuesday, Wednesday, Thursday, and Friday. And Serenada holds down the fort by working every day 8 hours on that machine. On machine 2, you have Ton Bone working 10 hours on Monday, Wednesday, Thursday, and Friday. I Don't Know works on Monday, Tuesday, Thursday, and Friday. And Chesterfield is a very dynamic and flexible individual, and he's able to be an expert in both areas and works on Monday covering stand-ups, Monday off, and Tuesday covering for Tom Bone, Wednesday for I Don't Know, and Thursday he gets a day off before coming in to cover for Sue Summery's Friday off. And this is a rotating day off as it goes. So everybody's happy with this. I have to say 100% satisfaction, and she assessed that with a 10-month post-implementation survey, and it really has positively improved the work-life quality. So what she did measure in addition to satisfaction was that there's no change in sick time, which I thought was maybe a sad thing, but she said, no, it's good that it stays the standard. The only thing they didn't look at was the incidents and injuries, were they more or less as a result of doing the 10-hour shifts. And there was a short time frame for collection of this data. One challenge is that sick coverage is a little bit tricky when you have 8-hour shift people covering a 10-hour shift person that's off. And depending on how you look at it, those rotations being 2 years could be a good thing or a bad thing. It's good in the sense that those people become experts in that area, but bad perhaps in that sometimes, that benefit of having that fresh set of eyes is a little bit lost there. But in 2014, we expanded it to 4 LINACs because it's so popular. And so the best part of this is that we've got 7 full-time radiation therapists staffing 2 linear accelerators instead of the traditional 8. So there's usually a lineup outside Marsha's door saying, can we join up? Anyway, the light's flashing, so that's it. Thank you.
Hi, I'm Michele Greig. I'm from the Simcoe Muskoka Regional Cancer Center, and I'm going to talk to you today about the hybrid RapidArc technique for stage 3 lung cancers. So as a relatively new cancer center, our physics team was looking to implement a treatment technique to use for late-stage radical lung cases. They searched for a technique that would be able to provide a high PTV conformity, be able to meet OAR guidelines and constraints, that would be able to control the low-dose bath that we typically see with IMRT-based plans, and that could standardize the planning process in order to increase efficiency. So a literature review revealed that the hybrid RapidArc technique had been successfully implemented for esophageal and breast cases, which face similar planning issues to lung with respect to motion and limited beam arrangement. So at our cancer center, what they developed was for lung, this hybrid RapidArc technique basically looks like this, which is a base dose plan, which is a simple POP technique, accounting for 60% of the total dose. This phase will help to minimize the low dose volumes received to the lung and also reduces the effects of motion interplay. We can then perform a preliminary evaluation looking at the lung V5, the V20, and the mean dose, and also the canal PRV5 maximum. And this information is used to decide if we need to make any adjustments to our gantry angle of our base fields or adjust the weighting of our fields. The lung V5 of the base plan is also used to indicate to us what size of avoidance sector we're going to need in our RapidArc planning. So then we move on to our RapidArc plan after that, which involves 2 partial rotations with the option of an avoidance sector. This helps to pull the dose away from the spinal cord, and by using an avoidance sector, we're further able to minimize the low doses that the lung receives, in particular the lung V5. We merge these 2 plans together, and that's what the patient is treated with for their treatment. So we do a 30 fraction treatment or 40 and 15. To implement this technique, our physics team generated protocol templates within our treatment planning system, and they conducted training sessions with the planners and also created test cases for us planners to work on. And this, and combined with a well-documented procedure, has helped us to be able to plan these cases with relative ease. So the first great thing about this technique is that it provides a predictive model very early on in the process. By the time that we've finished our base plan, we're able to identify what modifications need to be made to the plan in order to be able to meet our OAR guidelines and constraints, or even if it's possible, which is great. So it basically takes the guesswork out of our planning. The second great thing is that it drastically reduces our planning time. We're able to generate complex plans very rapidly. Most cases can be planned in less than an hour, although our physicists would like to boast that we can do this in 30 minutes. This is way less than what we would expect for IMRT-based planning and 3D conformal, which can take up to 10 hours to plan. Since its inception, we've now adopted a similar technique for our breast cases using IMRT, and we're beginning to explore the option of esophageal cases with this technique. Thank you.
Hi, my name is Katie, and I'm a radiation therapist practicing in the Northeast Cancer Centre at the Health Sciences North Centre in Sudbury, Ontario. I've come here today to share with you an innovative application of process improvement, which has been revolutionizing and transforming our radiation therapy department. It all started back in November 2012, when our hospital enlisted the help of workplace wellness experts WAVE Group to assess the quality of work life of staff at our hospital. According to the survey, staff in the radiation therapy department at the Northeast Cancer Centre were feeling as though their ideas and feedback were not being acted upon by senior management. Feelings of disengagement and lack of control over workplace decisions were identified as problem areas. This information proved to be very interesting to our management team at that time, as they had been thinking a lot about process improvement, lean culture, organizational excellence, and patient-centered innovation. They knew very well that some of the best patient-centered, innovative, and waste-reducing process improvement ideas would come from frontline staff, but there was a disconnect, or gap, if you will, in communication. Our Huddle board would become a tool to address both the need for patient-centered innovation driven by frontline staff and an increase in quality of work life for employees. In a nutshell, our Huddle board is a visual communication tool used to display and track process improvement ideas. Each treatment unit team takes 10 to 15 minutes each morning to huddle, and this is a time where waste and workarounds are identified and discussed. Once an opportunity has been acknowledged and a potential solution to that has been found, staff can fill out a Kaizen idea card and start the process of idea implementation. And Kaizen is just lean terminology that basically means change for the better. To organize our Kaizens, we use a pick chart, which separates our ideas into categories possible, implement, challenge, or kibosh. The location of the Kaizen on the pick chart will determine the work process required to move forward with the idea. We also use PDSA cycles, or plan, do, study, act cycles, to test our Kaizen ideas. If the implemented change results in the predicted outcome, it is simply adopted as part of our practice. If the change is only somewhat successful, it will be adapted and a new PDSA cycle will begin. If the change does not result in the predicted outcome, it will be abandoned. So far, there has been a total of 78 Kaizen ideas, 47 of which have resulted in actual changes in process in our department. The rest are either being adapted or have been kiboshed or abandoned. It's important to note that the success of our Huddle board would not have been possible without the Institute for Healthcare Improvements, or IHI's, online courses for quality improvement, which were generously funded by Cancer Care Ontario last year. These courses have given radiation therapists the tools and knowledge required to participate in process improvement, and to date, 73% of our therapists have completed or are working on completing their IHI training. As a team, we are very proud of our Huddle board and our commitment to process improvement. We hope that our board continues to inspire leadership and drive innovation in our center. Thank you.
Okay, thanks. Good morning. I'm Sandra Smith, and I'm from the Stronach Regional Cancer Centre, and I'm here to talk about the pre-radiation patient assessment. At Southlake, we've been finding that when patients come for their CT sim, they do not quite understand what the procedure involves, why they needed it, and they would have many questions about radiation and the harm it may cause. They were also sometimes not aware of the required preparation needed for the CT sim, such as dietary guidelines, bladder and bowel prep. We found that even the radiation oncologist reviews all this with the patient, but the patient is often overwhelmed during their appointment due to the stress involved. Oh, thank you. Therefore, it is not easy for them to understand or remember all these details and ask for all the questions about the specifics of the treatment. As a result, the patient attends a CT sim appointment unprepared, scared, in need of time to address all these concerns. We, the radiation therapists, need to spend time with the patient, time that is not always available in our 30-minute appointment, resulting in decreased efficiency. This has resulted in a gap between what we think the patient is ready for and how they really are. Following consent for treatment, all patients are booked for a 20-minute PRPA appointment with the radiation therapist. This allows the patient, relatives, caregivers time to ask questions and to be educated on what is involved over the next few weeks. We have developed an educational PowerPoint presentation known as a virtual tour for them to see visually the whole treatment process, from CT sim through treatment planning, plan review, and ending with daily treatments. One of the slides shows the patient in a treatment room. We discuss the position they may need to be in for the treatment, and are they able to achieve this, or do they need medication to assist them? We can talk about immobilization devices. This allows the radiation therapist time to address patient concerns and determine if the assistance of pre-medication or additional setup time is required. By the radiation therapist being able to assess the patient, it has enabled us to work more efficiently and create a more positive experience for the patient and family by relieving anxiety that the patients may have felt about radiation or their ability to comply with a rigorous course of treatment. Over the past 18 months, our data has shown a reduction in the number of rescheduled, cancelled appointments in CT sim, proving the effectiveness of the role. As we have compared our patient satisfaction data prior and following the implementation, we have. The PRPA therapist completes our post-discharge phone calls, and the results show an improvement in our ability to address our patients' needs. Oh, I did it in time.
Good morning, my name is Carrie and I'm from the Odette Cancer Center, and I'm going to be talking to you today about the whole CNS technique. The gap at our center is that we only treated a small number of patients each year with the whole CNS technique. So by the time a patient came, you could hear the buzz in the center, right? Oh my goodness, did you hear? The whole CNS patient is coming. Who was the last person to plan it? What machine are they going to? Who's treated it before? So it became very inefficient and outdated in our center. We also had a very fragmented way of introducing new techniques at our center, where sometimes you would hear sort of on the fly about a new technique that you would be treating a patient that day. So we tried something new, and it was going to be an interprofessional approach with physics to introduce IGRT to treat our whole CNS patients. So the innovation was pretty fantastic. We had some new people come to physics, and they had an idea to use IGRT for our whole CNS patients, and we were going to use the new 5-point hybrid mask and the SBRT body bags. For the very first time, we had a different look at an interprofessional group. We had physics, we had educators from planning and from upstairs. We had the electronic staff come on to our initial meetings, and we had both the planning team and the treatment floor team come to all the meetings. And this was done 2 months prior to the first start date. At those times, we decided that we'd have 2 full dry runs involving Pixie, our mannequin, where Pixie would actually be simulated. All the things would be done from planning. We would do the pre-check and do time limits for all of them. And what the innovation then is that we're going to use CBCT to do the match of the brain and the T and the L spine, while just doing a true shift from each of those points, which is 25 centimeters. The risk of this technique is that we're not going to correct in the sup and inf direction for the IGRT portion. So this group was able to strategize for the 2 months to take a look to see how we could decrease the chance of any error happening. The progress has been that we've addressed this innovation using our new technology and best practice. We've had some great professional relationships come out of this, where people are more willing to ask questions, and we have this new sense of what a team can look like. The interprofessional protocols were written prior to that first patient coming, and they were approved by all the disciplines. The planning time decreased by half, and the treatment delivery time decreased by 1/3. And it's been an overall positive experience that's led to enhanced collaborations in our center. Thank you.
Okay, well, I can start with a question. Michele, I have a question for you. Not speaking from personal experience, but I can appreciate that staffing challenges or tight staffing levels can be a challenge for a lot of management teams at different centers. Have you had any, or can you comment on if other management from other centers have approached you about this staffing model and the challenges and successes you've faced, and whether or not you can for them to implement it at their center in ways you could help them implement it at their center.
Well, lucky for me, it's not my innovation, so no one's asked me that. But I have heard today and yesterday quite a bit of interest. I did hear that there was one person that said, I wish you weren't doing that presentation. But anyway, that's okay. I think generally speaking, it's a way forward.
Tara?
Thanks for all the presentations. They were really great. I have a question for Carrie. Based on the success that you've had of using this technique to basically create a new technique for your whole CNS, can you see yourself using that method, that innovation method, to make changes to other techniques now, even ones that are already in existence?
I think that's been the greatest, for me, effect of this whole thing is that physics is actually coming to us months prior in the initial stages. So Young came to me and said, I have this new idea for this technique. And so now I've had other physicists come and say, what group do we need to bring together to do that? So yes, it's happening, and I'm really excited.
I have a question for Katie. The Huddle board was really intriguing as an approach and a formal way of looking at change and empowering frontline staff to engage in change. I was wondering if you could give us an example or two of a success in that, or the types of change that are brought forward and the PDSA process that you take.
Sure, I have a good one that's one of my favorite. Somebody came up with the idea, well, for lung treatments, we were using a lung board and we had clearance issues when doing cone beams because we were using the 2 pegs to separate patients' hands. And someone thought, why don't we just use 1 peg and have their hands around 1 peg, and it would cause their arms to be more straight and have more clearance. And it was brought up in huddles, and all the staff thought that it was a really good idea. So she filled out her Kaizen idea card and looked at what she would need to do to test that, came up with a PDSA cycle, presented it again to the staff. Everybody was okay with it and on board with it, and she just did this sort of on her own time. This was her little project, and we just adopted it. It showed that, yes, it was a good way to move forward, and everybody agreed with it. There was no resistance at all. It was just one of those implement ideas, and we just changed our practice now, and we do that for all of our lung patients, unless there's a patient that can't do that. But for most of our lung patients now, we're doing that, and we've solved a lot of clearance issues. So that was just a good.
And I imagine the entire process, must be beneficial to staff morale or engagement, or the level of empowerment that staff feel in the processes.
It is. I've done a few ideas myself, and it kind of gives you some control over your workplace and makes you feel like, yes, you can lead small change. It doesn't have to be a huge project, because sometimes taking on a huge research project can be a little bit overwhelming and you don't feel like you have the time, but you still want to have some kind of an impact on your workplace. So this is a really great way to get staff doing small changes and having them feel empowered.
So good morning, my name is Jacqueline Jacques. I'm here on behalf of Windsor Regional Hospital and the Windsor Regional Cancer Center to share in our experience in establishing an evidence-based journal club for radiation therapists. So for us, the need was identified when a new skin cream came into our department, kind of without some good scientific evidence about that change in practice. So as therapists, we started kind of reviewing the literature to see what we could find about that cream, and quickly kind of discovered that we needed to pull together both the skills academically and with experience from our group in order to kind of make that work. So we also needed a group approach to be able to kind of combine all that information. So we created a pilot journal club. Over a 1-month period, there were 9 therapists that participated, and we reviewed 2 articles and kind of came up with a good outline structure for how we were going to run regular journal club meetings. So basically, it was 1 article per meeting, and we would summarize the article as well as do a critical analysis of the article in a template PowerPoint presentation, kind of allowing therapists to fill in the blanks, and then follow up with a roundtable discussion on the topic. So this is a busy slide, but basically this is just to highlight that the pilot group did actually pull out some identified needs in order to make that journal club work, and that we did find supporting evidence in the literature to kind of support those goals and those needs for our group. So we did have to kind of pull out some really important ones and find some innovative ways to approach those issues. So those are kind of the three main points. That being that we kind of needed to come up with some really good roles and responsibilities for all the people participating in the group. And I do have a poster in as well, but it was showed yesterday. So if you'd like it, you can contact me for those details. We did actually secure a 2-hour of protected preparation time for each group each month in order for them to kind of independently meet and put together those details. As well as the scheduling of the journal club itself needed to kind of be able to accommodate as many people as possible in the department for therapists. So what we did is schedule that meeting over a 12-to-1 session, and then kind of move any machine gaps that we could into that 12-to-1 setting, and then encourage pre and post lunches so that that time can be maximized for attendance for all the therapists on the floor. And currently, the journal club is 3 therapists with a rotating leadership and a student, and we have 3 groups that rotate once per month. So we definitely do see a rise in frequency in scientific journal articles kind of in our work areas, which is kind of nice. Our presenter participation, we currently have 59% of therapists participating, and 100% of our students on a voluntary basis are participating as well. We do acknowledge kind of a gap in our treatment planning therapists, so hopefully we'll be able to get them on board shortly. Average attendance has been 59% as well, and to date we've reviewed 4 articles this year, and 2 more coming up hopefully in the next couple of weeks. So in terms of outcome measures, what we have measured through some kind of standard feedback forms, and recently just added a question about preparation from participants to see if they are in fact reviewing the articles prior to coming to the club meeting. And in June are planning a post-year-end recap session to see if we've actually attained those goals and the overall satisfaction of staff and participation. Thank you.
Hi, thanks for having me here. Sorry I'm a bit sick. I got a little sick on the flying barge of illness that brought me out here, so I'll try to make through this. So my name's Trevor Campbell. I'm the radiation therapy manager at the Jack Eady Cancer Centre in Lethbridge, the first of the 3 new cancer centers that are opening in Lethbridge or in Alberta. So with that, we were tasked with making all the new protocols, all standard operating procedures for our department. And one of the gaps we found was that there was no solid procedure for any kind of radical prostate treatment. And so we set a group aside and we started asking questions. And it was like, first question, what about the rectum? It's always a problem. There was no formalized what if. What if we don't match? What if we have, how many attempts are too much? How do we assess the patient was another good question. So in starting this clinic, we asked a lot of questions. And that brought us to a solution. So we came up with a bunch of solutions, and we came up with a complete system for our prostate imaging protocol. So first off, we had to make sure that the therapists were all consistent. User variability was checked. We did a little paper on it, and lo and behold, just like all the other literature that's out there, the therapists are very consistent and very good at matching cone beam and soft tissue. The patient prep, or what like we say at Jack Eady Cancer Centre there, is, or lack thereof, I guess. We don't ask the patient to do anything special. We say just have a bowel movement before your treatment or CT stimulation, and we ask them to void their bladder about an hour beforehand and drink 750 milliliters of water. That's about it. We did have one thing that came up is how are we going to match the rectum, because again, always a problem. So what we do is we created a matching rectal volume, or the MRV. You can see it outlined there. It's basically a growth of the contour that the doctors that do, and we grow it by 3 millimeters, a centimeter above and below the PTV, and that's what the therapist matched to. And there it is there again. So we had guidelines for the scans as well, guidelines, how many actual cone beams we can take, because that was an issue. We were going to, the intention was, and we still do, cone beam every single day on the patient, so we need to know how many was too much. We had to know what the priorities were, so it was prostate, rectum, bladder in that area, and we also needed to know what the patient assessment was going to be, because if we were doing something different than was done in the rest of Alberta, we had to know exactly what we were doing. So we implemented an NCI grading toxicity for the patient, and that went over so well, and we did a little paper, it was taken to Carol. That went over so well that we've actually implemented that throughout the department so that the patients are all assessed by the therapists and the nurses, and the doctors use that as their assessment tool. So outcomes, you can see the first 120 patients, very limited or zero rectal toxicity. Patient satisfaction is very high, so there's opportunity there for two studies. Therapist job satisfaction is up. Template for future changes created, and the next steps, we're going to do some bladder scanning because 55.8% of our patients fail cone beam is because of bladder, so we're going to scan it with an ultrasound so we don't have to irradiate them, and that's it.
Morning, I'm Joanne. I'm from the Saskatoon Cancer Centre. I'm going to be talking about the multidisciplinary review clinic that we've implemented in Saskatoon. So the idea was to bring holistic care to the patient, to save the patient steps, to save the patient effort, do what we can to make things easier on them. So the gap, our problem was that we were unable to address all of the patient's concerns at one time or within a short amount of time. Especially during their review appointment that they had, typically with a radiation therapist and the radiation oncologist. Sometimes we're lucky enough to have a nurse. Sometimes they don't want to work with the oncologist. But there were a lot of questions left unanswered to our patients. And then in between their weekly review appointment, we spent a lot of time and effort trying to answer these questions for them and then hopefully get back to them within a week. And that was a long time when they're spent waiting, and they've had a lot of uncomfortable waits already. So our innovation was a new approach to the review clinic involving an entire team. So we gathered a team, and during their weekly review appointment, every resource is available to them. Our patients actually have a form they fill out, basically to triage. So on their weekly review day, they're given a form when they come in for their treatment to decide which member of the team, or any, they can do any combination, that they would like to see, maybe all, or maybe if they felt really fine and didn't feel like they needed to see anybody, so that we better managed our time. So our team now includes, we have a doctor, we have our dietitian, we have our nurse, we have a pharmacist, social worker, radiation therapist, and right in the middle of it all is our patient, because we're all there, and there are often times when we are all in that room. I'd like to point out that the pharmacist has also kind of opened the door to medical oncology, and they help us sort of incorporate them into the team, and sometimes they're with us too. So we are now able to answer almost every question the patient has, any concern, all at once. So it's been a huge benefit to the patient. They love it. Huge to us, especially as therapists. We've been able to learn so much from the other disciplines. Yeah, biggest advantage, honestly, surprisingly to us, is the pharmacist. They've really changed the way we've done things, because our radiation oncologists were really standardly prescribing things, and they've really helped them individualize. And I think some of their pharmacology skills were fading a bit, and they've really brought them up to date. So thank you.
Hi, my name is Colleen Dickey, and I'm from the Princess Margaret Cancer Centre, and I'm here to talk about magnetic resonance guided radiotherapy and the innovative way we've designed it and applied it at our centre. So in the era of highly conformal radiotherapy, there's an increased demand for targeted image-guided radiotherapy approaches. And magnetic resonance imaging, or MR imaging, provides superior soft tissue contrast. MR-guided RT approaches provide opportunities for better target delineation, increased dose to the target, and decreased dose to the normal tissues. In our current program, we do have an MRI simulator that treats various anatomical sites, such as CNS, pediatric, soft tissue sarcoma, liver, lower GI, and gynecological diseases as part of our standard RT simulation procedure. And we do have research procedures that treat lung and brain. And as Jesse Abbott spoke about yesterday, we have some interventional procedures where we actually target biopsies with the MR, and we can place our brachytherapy catheters with the MRI used as guidance. But currently, the brachytherapy suite is located on a different floor than the MR simulator, so they're separated in time and space. So the innovation was led by Dr. David Jaffrey, and it combines everything in one area. So the MR simulator is in the middle of the Linac bunker and the brachytherapy suite, and the MR translates on ceiling-mounted rails to the brachytherapy suite and the Linac bunker on rails. So you're able to image in all three rooms. So again, looking from the top at this design, on top is the brachytherapy suite, middle MR room, and the lower is the LINAC bunker. And this suite combines magnetic resonance imaging for external beam and brachytherapy, which is quite novel, and also has many robotics components that are novel, first of its kind, so it has delayed the project quite a bit. So some of the challenges that we've faced, and I've been involved in the clinical implementation phase of this project, is that we want to maximize the use of this facility. So if you can just imagine the scheduling concerns when in future we want all three streams to be working efficiently and perhaps in combination. And also a very constrained space in the traditional sense. So in order to overcome some of these obstacles, what we've done is, instead of just writing standard procedures and policies, we've also incorporated mapping out where people are in space and in time, and also where the equipment will be placed. Even for the emergency procedures, which is we're ongoing right now, and seeing the challenges that that all incorporates. We have some operability issues that we've had to address in the design. One of the biggest is that the MR requires isolation from radio frequency noise, and the linear accelerator is a source of radio frequency noise. And also, of course, addressing the MR and radiation therapy safety concerns. So the MR prohibits ferromagnetic objects, and of course, the linear accelerator and brachy equipment are all ferromagnetic. So these are the challenges that we face that we're working carefully on overcoming with the overarching radiation and MR safety theme. Thank you.
Joanne, I just had a question for you with regards to, do you have a dedicated therapist in that role?
Yeah, we do. Yeah, we always have one of our senior therapists dedicated to it, and generally staffing-wise, we have another one as well, so usually 2 therapists dedicated to it consistently.
Joanne, I actually have another question for you. In terms of running this review, do you have any challenges with coordinating the team? Do you have a specific designated time where these practitioners are all available, or is it someone you just page them if they are needed for the patient?
Initially it was, because it's just not how things were set up, but it was basically a reassortment. Our dietitians, each of them were scheduled for so many physicians' patients, so now their time is set out for them. This physician has his review clinic this half of the day, and they come to that, so they're able to catch all of their patients during the week, and there's still some free time in between if they're not necessarily needed in an appointment, where they can catch the occasions that come up where they need to be paged to or something. So yeah, just a matter of reassorting the staff, and once everything fell into place, it worked really smoothly. Yeah.
Jackie, I have a question for you, and it comes back to Tara's comment at the beginning about it's all well and good, and there's a lot of buy-in at the start of an initiative, and everyone's very excited about it, but I can imagine something like a journal club, it's hard to maintain that energy. And do you have any challenges with keeping up that excitement about it?
Maintaining it is kind of a challenge. Probably every single time we meet, it's kind of a challenge. By having defined roles, that's been kind of our strategy to keep it rolling. So we do have a kind of a director role, kind of in the background, making sure the bookings are completed, the room's ready to go, that the team itself is working on the article, that the article has kind of been reviewed and is sound enough for review, and allowing kind of the team itself to work independently. So we actually allow the teams to choose their own articles, kind of has helped to keep the motivation rolling, and that they can kind of choose around a topic that's relevant to their current practice. And then that rotating leader in there kind of gives you that one person to be in contact with to make sure things are kind of rolling on time. So for us, we've kind of broached that challenge by keeping some really good order in roles.
I have one last question for Colleen. That's obviously a huge innovation, disruptive and large in scope. And I guess just a comment, as you said, it's led by Dr. Jaffrey, but there's a lot of involvement. There's a huge team involved in that. I wonder if you could comment on the therapy engagement in rolling that out, the level of the radiation therapist engagement.
I think largely up until the last couple months, the project has been in the construction phase. I think it's been 3 or 4 years, to my understanding, from the original inception of the idea to this point where we're about to launch in 2 months. So I've been brought in as a radiation therapist from that perspective, from the clinical perspective, in the last 4 months. And I think they always wanted, from the very initial start of the clinical implementation, having the right clinical people involved. So I've tried to involve all the people who I feel are experts in each clinical scenario to write the procedure, because one of the things I've always wanted to do in all the spaces in the hospital is to have the person who knows the procedure best write the procedure, which doesn't always happen. So involved in that then is just tying into all the structures that are existing in the hospital and the approval processes, and learning about that has had its challenges. But yeah, radiation therapy has had a big representation.
Okay, great. Thanks to you four. Thanks to all the presenters.
So I won't keep you guys too much longer. I'm just going to give you some of my thoughts before we break for lunch. And I wanted to congratulate our presenters again on their innovations. This session is a testament that there is a lot of hard work going on across the country, and I'm sure there's a lot of other ideas out there that haven't been presented today and through the whole conference. So, you know, in short, innovation to me, really simply put, is ideas into action. So, you know, ideas themselves sound, you know, they can sound great in the theoretical framework of an innovation. You know, developing the idea is really the easy part. Turning it into action is sort of that leap of faith that things will turn out the way you would hope to. But often there's setbacks, and you have the naysayers that say it's not going to work, and just those types of challenges. So, you know, saying that, to say these innovations, you know, these projects went from ideas into action is actually quite commendable. And I think it highlighted the scope and nature of really the initiatives that are happening around the country, improving and informing our practice. So we saw a lot of process improvement, high-level technological advances, and it's evident that there is a high degree of collaboration, investment in time and resources. So all those things have to be considered for when you're doing an innovation. And so innovation, you know, we saw some from small centers and large centers. And I think regardless, innovation is innovation, and it's important, and you're making some sort of impact in your practice, regardless if you're impacting a small group of patients or you're totally changing your practice. So some of the themes, Kaitlyn and I sort of divided up the presentations into what we thought were the most common themes from this session. So one, advancing treatment technology, communication and collaboration, staffing models, and RTT roles, just kind of for interest sake to see kind of where we're at with innovation. And then I sort of tied all that in and thought, well, what's the common thread between all of this? And really, it was improving overall patient experiences. So that's what we're here today and at this conference is, you know, whether it's process improvement, reading journal articles to inform, you know, evidence-based practice, improving our evidence-based practice, or actually, you know, more technical innovations or personalized cancer medicine. In some way, we are improving the patient's experience. So why is innovation important? These are just some of the reasons I thought. I mean, this list is obviously not exhaustive, but you know, we are a highly evidence-based profession, and we have come a long way from, say, even 10 years ago, even 5 years ago. So we're always evolving. And the second point, keeping current with evolving technology and knowledge acquisition. So if we, as Kaitlyn said in her intro, or I think it was her conclusion yesterday of yesterday's conference, that if she had the same knowledge and she didn't, you know, from when she graduated, and she hadn't, you know, engaged in professional development, and, you know, her skills or skill set would be outdated. And I think that that falls true for all of us. And job satisfaction. I think that when you take on a project and you kind of have it as your own, and you go through the ebbs and flows and all the, you know, tribulations of putting together an innovation and the challenges. I think in the end, when you come out with some sort of product, that there is some job satisfaction that goes along with that, and fostering collaborative relationships. And I think it's also a good introduction to the novice researcher if large-scale research can be very intimidating, I think, for a lot of people, but an innovation doesn't have to necessarily be highly technical. It can be a process improvement, so I think this could potentially be a really great way for people to be introduced to research. And then more innovation. I think one idea, you're never really finished, and one idea flows into another idea. And if your innovation doesn't take the path that you thought, it always kind of is branching out. So I think innovation isn't really an endpoint; it's more of a journey. And then challenges to innovation. We've seen today resources, time, financial resources, unexpected and unintended outcomes, and fear of failure. Sustainability is a big piece. And sometimes when you're making bigger changes, with certain staff and staffing models, there is a bit of resistance to change. So those are just, again, not exhaustive, but some of the things that I came up with. So next steps. We're hoping this session was beneficial for everyone, and maybe we can create an online forum or some sort of community of practice, like Kaitlyn said, to engage the wider community, engaging and talk about different innovations that are going on around the country, and to continue to showcase innovation across Canada, and to also foster interinstitutional collaborations. And this is always going to be something we're doing, continuing to build our evidence-based body of knowledge. So I wanted to leave you with this quote. I think this one really resonated with me. What we've done to encourage innovation is to make it ordinary. And that was quoted by Craig Wyna, who's the Chief Innovation Officer of Procter & Gamble. And I think this one resonated with me because I think in radiation therapy, we've really adopted a culture of innovation and research. So the concept of innovation isn't unique. The innovation itself is, but I think that we are really lucky in the fact that we're very progressive, and we like to always be pushing the envelope a little bit more. So I'll leave you with that. I have just one last thing to note, that for any of your colleagues here that aren't here today, we will be broadcasting. This session was filmed, so we will be broadcasting at a later time, so you can go home and tell your colleagues and let them know that this will be available. And hopefully you left with some good ideas to take back to your center, and please give us feedback, constructive feedback, because we're hoping we can run this session next year too. Okay, that's all I have to say. Thank you.